Welcome. We're so glad that you have joined us today. My name is Reverend Dr. Waltrina Middleton, and I am the Executive Director of Community Renewal Society. Community Renewal Society is a 137-year-old nonprofit committed to eradicating racism and poverty. We are committed to a vision of beloved community, inclusion, justice, and faith. The latter is very important because we are unapologetic in our belief that to identify as a faith-centered organization also means you are centered on social justice. The two are not exclusive. And that's why we are here today. Certainly, COVID-19 has had a deep impact on faith communities, radically transforming the ways we enter into worship, community, and how we engage mission and service while socially distancing. We are amidst Ramadan and in the season of Easter. And at the intersections of our faith, we are also wrestling with issues that certainly predated COVID-19, such as classism, racism, and poverty, and other social disparities like police violence and the inadequacies in healthcare. Today's town hall entitled A Bomb in Gilead. This is one of 3 town halls in a series entitled Color, Class, Culture, and COVID-19. Town Hall 1, A Bomb in Gilead, focuses on health disparities. Town Hall 2, Jesus and the Disinherited, will focus on socioeconomic disparities. And lastly, Town Hall 3, Ubuntu, I Am Because We Are, will focus on the impact on the global diaspora. We are so honored that we have 2 dynamic speakers with us today, Jewel Love with SoulStirring LLC, and Dr. Ulysses Burley with UBtheCURE. I want to welcome you both, Jewel and Dr. Burley, for being with us here today. I'm certainly going to create a space where you can share more about your organization, but I want to let folks know that Jewel Love, first of all, with SoulStirring, is a researcher, a strategist, a public health scholar that's committed to the quality of life, well-being, and health centered on communities of color and beyond. Dr. Burley himself is also a clinical public health practitioner that focuses on intersections of his work that includes poverty and religious intolerance, addressing religious intolerance. Thank you both. Ms. Love, will you please introduce yourself and share a little bit more about your work and what brings you to this conversation today?
Indeed. Good afternoon, everyone. I'm really happy to be here. I have spent a number of years focusing on public health, social well-being, with a real lens around trying to help people change, and we call it behavior change, but ultimately change their lives for the better, in particularly when it comes to their health. I usually work on really hard issues across communities of color. And a great deal of my work is in this country. I have had the opportunity to work outside the country. I like tough issues, but I am really focused on our people, our brothers and sisters, and how is it that we can thrive? Because if we're not thriving in our health life, more than likely the rest of our lives are a bit more of a challenge. So I'm excited to be here with Dr. Burley and Dr. Middleton, and looking forward to the conversation.
Thank you, Jewel. Dr. Burley.
Thank you, Reverend Dr. Middleton. Again, my name is Ulysses Burley, and I'm the founder of UBtheCURE LLC, a faith, health, and human rights organization with expertise in HIV and AIDS. As mentioned, I am a clinician by primary training. I call myself a recovery clinician, as I have dedicated my career now to the issues of health equity, mainly around HIV and AIDS. Some time ago, over 10 years ago now, when I was in my training, I did a fellowship in Buenos Aires, Argentina, where I was caring for people living with HIV. And it was then that I was introduced to the social determinants of health, but more specifically the social determinants of HIV and AIDS, and how it was in which the social diseases, social ills were impacting people's physical health. I realized that no matter what we did for patients in the hospital, we would always send them back out into a world that made them sick. And so I began to shift my focus from diagnosable diseases to the diseases of society that leads to diagnosable diseases like HIV and AIDS, things like poverty and discrimination, racism, corruption, religious intolerance, and otherwise. And so I have now been operating under the model of treating people and not just disease, because I believe that if we put people first, then we will in turn eradicate disease as we know it. I'm very excited to be a part of this discussion today, and I'm looking forward to the engagement of the panelists and those who have tuned in.
Thank you, and welcome to you both. There are just so many things to talk about, so we're going to jump right in. I want to let our community members that are joining us today know that we know that this topic runs deep and we will not be able to cover everything, but we're going to do our very best to address some of the issues, particularly how they impact communities of color and impact those communities in a disproportionate way. We know that in Chicago alone, more than 70% of the cases of COVID impact communities of color, and in particularly African-American communities. And that number goes up and it increases even more when we include the Latinx community. And so this is certainly a crisis on many levels. And I want to start with, and also before we begin with our conversation, invite our community to also submit your questions under the Q&A option that you see on your screen, and we will have time at the end of our discussion to take questions from our audience, and we thank those that submitted their questions in advance. But I want to go back to Dr. Burley when you spoke about HIV/AIDS, and both of you, Ms. Love, have both expressed that there's something very familiar with COVID that reminds you of the challenges that we face in our society around HIV/AIDS. Could you speak to what are the similarities and what resonate as familiar with COVID-19 and the challenges that we face, the crisis of HIV/AIDS?
Sure. Well, first, from a scientific perspective, both HIV and COVID-19 are believed to be zoonotic diseases. That is, they originated in animals and then was transferred into the human population through a process called zoonosis. From a public health standpoint, we know that HIV became a global pandemic as a result of globalization. And so the colonization of the continent of Africa, the industrialization of the continent of Africa that then led to a global workforce. And as that connection between populations increased, so did the likelihood that an opportunistic infection like HIV could then traverse across the globe. And so likewise, we are seeing that same phenomenon in effect with COVID-19, as we know it originated in China and has now made its way across the oceans to impact the whole world. However, the most glaring similarities between the HIV and AIDS pandemic and the COVID-19 pandemic has nothing to do with science or public health, and has everything to do with the social determinants of these diseases, more specifically the way in which they have stigmatized certain communities, the way in which they have disproportionately impacted certain communities. And as a result of that impact, the way in which we have responded to it, or the lack of response to it. Next year, we will be 40 years into the HIV and AIDS epidemic. More than 40 million people have died, with more than almost 40 million people living currently with the disease worldwide. And one of the reasons why we are still battling HIV and AIDS 40 years later is because we got off to a slow start responding to HIV and AIDS, particularly here in the United States when it was first identified in 1981. Our government really downplayed the HIV and AIDS epidemic, because at the time it seemed to be only impacting people who identified as LGBTQIA. And for many of society, those kinds of people were people who were expendable. As we saw that disease began to progress, it began to impact communities of color disproportionately. Likewise, we saw these communities of color as expendable. And so the level of awareness, the level of action, the level of urgency was simply not there as long as it was impacting people who we deem sacrificial. Likewise, the moment in which we realized that COVID-19 was disproportionately impacting poor people and Black people, you began to see calls to reopen the country. You began to see calls to disband the pandemic working group. On the federal level, you began to see calls to return to business as usual, despite the fact that cases are still increasing and are disproportionately impacting communities of color. And so there is an inherent stigma that is associated with COVID-19, as it was with HIV and AIDS and continues to be with HIV and AIDS, that exists now. And as a result of systemic and systematic bias and discrimination against certain groups of people who we have been calling essential, but really deem as expendable.
Right. And thank you for that. Ms. Love, how would you respond to that? I know that you have a unique perspective as well. How do you make that alignment between then and now?
Well, there are two things that I am seeing and hearing about that really concern me. So we take an example. Someone doesn't feel well. Now they work somewhere where their colleagues have been diagnosed with COVID-19. And they immediately go into a space of denial, right? So the combination of, oh, no, I'm okay, which means that I feel a sense of shame and I'm afraid. We can't afford, as people of color, as communities of many colors that we're talking about, if we don't feel well, and it's in this now range of symptoms, right? We don't want to stand in the shame and the fear and the denial. And the reason is, similar to HIV in the beginning, we didn't know a lot. This particular disease, like HIV, like Dr. Burley has talked about, it was evolving. It was continuing to evolve. But there's a difference. With HIV, you had to go do something, right? This is communicable. It's out there. And even though we are disproportionately, being affected by it, it doesn't know a color. And so that's the piece when we get down to some specifics and what we're hearing about and what we're seeing, whether it's in our own social networks, whether it's because colleagues have shared, we cannot rest ourselves in fear, in shame, and denial, because this is not the fault of anybody.
And I think when I'm thinking about health crisis, and as I shared earlier, that there are issues that impact communities of color disproportionately that predated COVID-19. But COVID-19 certainly helps to shed light on some of those disparities. What are some of the disparities that are being highlighted, and in particular that impacts communities of color and those intersectional communities that's so critical that we lift up right now? Either of you can jump in.
Well, I mean, when you look at this, I mean, it's a big issue around equity and access. Now, we can go to specific diseases. We can talk about diabetes. We can talk about hypertension. We can talk about strokes. We can talk about respiratory issues. There's a reality. If you are low wealth and you are a person of color, the racism that you have to deal with versus someone else who is poor and white, when you go into the health system, we don't take a close enough look at. The effect is so different. You know, we've asked for years for the appropriate support, the appropriate kind of funding to be able to address all of the disparities that we're talking that are now manifested. The light is shining so brightly, you know, because of the kind of disease that COVID-19 is. So, you know, we're like in a spinning wheel. Now we're gonna either get off, right, from this point forward, and we're going to make another set of demands in a different kind of way, or we will continue to be so at the bottom, not only of, you know, sort of health and equity and access, but just the ability to address these issues. You know, this is the other aspect of the problem. The ability to address, you see the overwhelming nature of what's happening. It's very difficult to get well when you're getting sicker. You know, it's very difficult for a respiratory situation to be upon you and you have other physical ailments. And so we've got to now help, you know, everyone in this space of planning and this space of social equity and health equity and access, and say, what are we going to do differently? Because we've got to move the needle. We don't have a choice now. Are we okay now that we're backed in a corner and backed against the wall? Are we now ready to come forward and make some shifts and transform issues that have been around just far too long?
Well, Dr. Burley, I mean, Ms. Love raised some good points about some of the systemic challenges that we already face as a community as it pertains to health, equity, and access. From a clinical perspective, how do we wrap our minds around that in this moment of COVID-19, and also begin to think about how we address it and use this moment to transform the way that we address access and equity in the health arena going forward and beyond?
Sure. Well, again, it harkens back to the social determinants of health, which are the structural conditions in which people are born, grow, work, live, and age. It includes their neighborhood and built environment, their economic stability, their social and community context, their level of education, their health, but also their access to healthcare. Now, as Ms. Love mentioned, you know, Black people have pre-existing conditions that predispose us to COVID-19, right? But let me be clear, there's nothing about our Blackness that makes us more susceptible to COVID-19 than anyone else. Likewise, there's nothing about our Blackness that makes us immune to COVID-19 more so than anyone else. However, there is something about our Blackness that makes us more vulnerable to racism and discrimination, which as a result then manifests as these health disparities. And for that reason is why we, you know, lead in 8 of the 13 leading causes of death in the United States, some of which are pre-existing conditions for COVID-19. But it's not because of our Blackness, it's because of the structural conditions that have led us to these moments. And so when we talk about redlining, which is ever present in the city of Chicago, you think about poverty centers, poverty populations that were created intentionally and still exist today. And so, you know, most of our Black and brown communities are industrialized regions, which then make us more vulnerable to lung and air pollution, which then increases our levels of asthma and COPD, which are pre-existing conditions for COVID-19. Likewise, most of us live in food deserts. And so we don't have access to fresh fruits and vegetables, which then means that we have to meet our daily caloric intake via other things that are available and likely less unhealthy. And so then that leads to hypertension and obesity and diabetes, which then leads to kidney failure, which are also pre-existing conditions for COVID-19. When you think about our access to even healthcare, we don't have grade A hospitals in our communities. And so if we get
hospitals at all, because
or at all, right?
So on the south side of Chicago, hospitals are being closed.
Exactly. So if we're getting sick, well, then if you have to travel just to access healthcare, then that becomes prohibitive. And so all of these things add up together to put us in the situation that we find ourselves in, that then translates to a disproportionate rate of medical diagnosis in COVID-19. And so you ask the question, what are we as healthcare providers doing to address these social determinants? And up until this point, it hasn't been much. Just last year, a bill was introduced called the Social Determinants Accelerator Act. And just recently, as a result of COVID-19, another bill was introduced called the Social Determinants Act that is trying to empower community health centers, hospitals, and otherwise to have more funding and to do more programming around what happens upstream in societies that lead to these downstream medical diagnoses that then drive people to the emergency room or to their federally funded community health centers to receive care. So, as you say, COVID-19, I hope, is a teachable moment. It definitely isn't the first moment, but because it's a global pandemic and all eyes are attuned to COVID-19, I'm hoping that now we will get the attention of the larger community to now act in a way that treats people and not just disease.
Well, I mean, we all talked about HIV/AIDS, and one of the things that stood out to me are some of the similarities following the hurricanes Rita and Katrina and the broken levees. And to your point, how there was an outcry, there was a great urgency to respond, but people were criminalized. Images of people doing everything they can to survive was taken out of context. And we even had government officials and their spouses that said, well, they're better off now than they were before because of the government aid that was provided. But there seemed to be a lack of affirmation of human dignity and a lack of urgency to respond to the ways that disaster directly impacted communities of color, displaced communities of color, and removed families, separated families. And so I'm seeing the common thread here of lots of family members being wiped out by this disease, communities being separated from their loved ones, people being forced into poverty because of not being able to work or unemployment. Some of those narratives that impacted disproportionately communities of color resurfacing. And so we did not necessarily learn from Hurricane Katrina. Maybe we learned from HIV and AIDS, and we're hoping that we will learn from this moment now. But what are some of the tools, particularly as it pertains to health disparities, that as a community, we can organize around ourselves so that we are not repeating the past and that we're not allowing government to further harm our humanity by its lack of response or lack of care for these communities that are disproportionately impacted. Ms. Love, how would you like to respond?
Well, I think first we have to realize that everybody's not going to get it, and they aren't going to respond in the most humane of ways. I said, secondly, I'm a planner now. I'm a program planner. I believe in creating strategies for change. We have to change our thinking and be much bolder and ambitious with our goals. So when I say that, I mean eliminate diabetes. Every home has broadband. There are no food deserts. I don't think we're ambitious enough in that way. Innovation and technology, you talk about strategies. We're too behind in health, in social well-being, in public health, the integration of technology to support people toward wellness. Also, we have to make sure that the teams that we form to do this work are really filled with servant leaders. And when I say that, I'm talking about, one, people who are egoless. They are not looking to be celebrated. and they believe in humanity first and foremost. We are in a scenario where the question that's not being debated right now is, you know, what's the value that you put on human life? You know, that's what we need to be really pushing elected officials, et cetera, to answer: value on human life. And so even before, and I have thoughts about strategies, we get there, we may have to restructure our own thinking and the collaborations that are happening. And then when we think about our partners and our funders, we have got to be in collaboration and partnership with funders who are there for the long haul. Not 6 months, not 12 months, because these issues, these challenges, these problems, they're not overnight. But if you're a believer in transformation and generational transformation, you've got to make that kind of financial commitment and be willing to wait for the partners that are, so that we can get the change that we absolutely deserve for these and for our communities of color.
Well, Marsha Borders, along that line, raised the question, what can be done to help the community to stay home and wear masks since we are very vulnerable? And more specifically, she asked, how do we as a community take responsibility for protecting our own? If they don't care about our community, what do we need to do? And I think also I want to add to Marsha's question, because Dr. Burley also talked about some of the stereotypes of the stigmas. You know, how do we also, alongside Marsha's concern, help to disrupt some of the misinformation out there as it pertains to our community?
Sure. So first of all, let me dispel the myth that people of color, but particularly Black people, don't care about their own health and therefore aren't following the current guidelines in place of social distancing, of wearing masks. In fact, the Associated Press recently conducted a poll that showed that overwhelmingly Black people were more likely to wear a mask outside of their home at 83%, than whites at 67%, and Latinos at 64%. So I want to first and foremost dispel the myth that our behavior is a function of our disproportionate impact with the COVID-19 virus, first and foremost. Secondly, you asked the question about what it is that we can do as communities to better engage health equity as it relates to these issues of social determinants and how they impact communities of color. You know, first and foremost, we have to engage the political process by voting, right? It's the most accessible way to make change at the top, even in spite of massive voter disenfranchisement movements. But we have to vote, and in doing so, we have to demand of the candidates for whom we are voting, you know, that they take us as a priority. You know, I think about the upcoming elections in November, and I think, you know, about 4 years ago, where would we be as a country right now in the midst of this pandemic if we had voted differently? And so that becomes something that's key, and it's something that we can all participate in regardless of our class or race or socioeconomic status. We also have to engage the healthcare system in a different way. You know, Reverend Dr. Middleton, you mentioned the mistrust, and there's historic mistrust of Black people of the healthcare system. You know, when you think about Henrietta Lacks, someone whose, you know, cells were taken without her consent and then used to, you know, basically develop vaccines and things that keep us well, but also used to generate billions of dollars that her family still hasn't seen. When you think about Fannie Lou Hamer, which many of us identify with as a political and civil rights leader, but someone who went into the hospital to get an appendectomy and left without a uterus because she was sterilized without her consent. They call those the Mississippi appendectomies. When you think about Dr. J. Marion Sims, who we call the father of gynecology, who basically got that moniker as a result of testing his practices on Black women without anesthesia. We have reason to not trust the healthcare system. Maybe most famously, the Tuskegee study of untreated syphilis in the Negro male. And that only ended in the late 70s, right? And so many of us still remember that. Many of us carry that with us into hospitals and doctors' offices, or many of us carry that, and that's what keeps us from engaging the systems. And so, we're least likely to have health insurance, and that's political mostly. But even when we do have health insurance, we're the least likely to use it as well. And that harkens back to the medical mistrust that exists. And so, on the one hand, you don't want to engage a system that continues to traumatize and abuse you. But on the other hand, you also don't want to be left out of a system that depends on widespread population participation to develop new and innovative treatments and cures based on those who are willing to participate. And so I say this in the sense that eventually we will have a vaccine for COVID-19. In fact, it's probably the only way that we'll get out of the current situation that we're in right now in terms of the restrictive measures, staying at home, social distancing, wearing masks and gloves.
And that's for people who are privileged to be at home. I mean, that doesn't even speak to those persons who are incarcerated, those persons who are displaced and homeless. I mean, we opened up talking about the intersections. I mean, we already know about the disparities with Black and brown persons that are incarcerated, and not being able to ensure that those individuals have access to masks. Like, what's the capacity to ensure that they have social distancing in place when you're in a jail cell with multiple persons, and even those that work there don't have access to masks or gloves, putting everyone in that system at risk. And just the failure for with homes, for retirement homes or nursing homes, or LGBTQ persons of youth of color that are displaced and that are on the street, that are largely marginalized on many levels, don't have access to these resources. And so when we're thinking about having access to healthcare, I'm also thinking about those that don't have a choice, those that are incarcerated, those that are displaced, they're homeless, those that are institutionalized in some way. And which is one of the reasons also why it was really critical to have both a clinical as well as a spiritual health practitioner, because when we're talking about caring for humanity, gaining that trust, not just because of the failures in the healthcare system, but also the failure to have access to the system or to be treated with humanity when you are restricted in your lifestyle. Ms. Love, would you like to add to that?
Let me take one piece of it. I think what's incredible about right now is that we're able to watch certain states, certain governors execute, solve problems in very real time, make changes that we thought could never be made to systems on a state level that are being made. So let me just first, when we look at nursing homes, this all started in a heavy way in Washington State in a nursing home, right? So for the most part, people probably in public health, those that were really paying attention, who are the gatekeepers, you knew and realized that because it's a communicable disease, that if it gets into nursing homes, and it would, the spread was going to be tremendous. To me, that's a place and space where the demand, because of the number of deaths and the challenges and the way that nursing homes, which are very private for the most part, and how they are mandated and regulated on a state level, that one, you have seen other elements of the health system and the political system have to come together to say, wait a minute, we have to be helpers in this, because you are also seeing in the nursing home environment where, because of how they're regulated, they weren't asking for the help that they also needed. And they are not equipped like a hospital. They are not set up, not that they don't have doctors and nurses and CNAs, but they're not set up for a fast moving pandemic that all of a sudden comes on them. But I think we can look at, some of the systematic elements. It's going to take a minute to solve, but we can't lose sight of where we are seeing changes that make sense and that are bringing about good solutions. And I want to say, I think that in a lot of states, this is a place and space with nursing homes where we are seeing that be able to happen.
I want to add a question from Marion Jones with St. James Catholic Church here in Chicago. And she has a specific question about the cost about having access to testing. And she wants to know how much testing has been done on the south side and west side of Chicago, who is being tested, where is testing being done, and how long does it take to get results? And I'm no pressure to answer all of those, but if you have any insight on that, and I'll take that to Dr. Burley, if you could share or respond.
Sure. So as far as I know, we don't have the numbers based on regions in Chicago. Now, you can search by zip code to find where testing is accessible to you in your region. But most of the regional breakdown has been done on the state level. And Chicago is considered to be in the northeast region of Illinois. I know as a city, as of yesterday, Chicago had tested almost 95,000 people and was averaging somewhere along the lines of 3,000 tests daily. Now, just from a quick Google search, you can locate a number of different testing sites in your region all over the city. The question is, are those tests for free? Are those tests covered by the CARES Act that was recently passed? And that's where things begin to get fuzzy. And so just in my own research, many of the health clinics that exist, whether private or public, many of the urgent care clinics that exist are now offering COVID-19 testing by appointment only. But you have to have insurance. And if you don't have insurance, the test can cost you as much as $250. So that's prohibitive for a lot of people. Now, there are also about 165 community health centers in the city of Chicago. And you can search at findhealthcenter.hrsa.gov to find which one of those community health centers is closest to you. And then you have to call that health center to have a conversation with someone to schedule an appointment. And that test would be covered as a result of it being a publicly funded community health center. But, I think this is all around, it really shouldn't be that hard, right? To get a test for something that is impacting everyone. And that continues to be our Achilles heel, not only as a country. We've only tested less than 2% or a little over the 2% of the population here in the United States. And so that's maybe 8 million tests. We have 330 million people for a virus that we have no natural immunity to. So everybody is vulnerable. Here in Chicago, we are doing better than most states, but we rank fourth in the country in Illinois in terms of the number of coronavirus cases that currently exists. As a country, we're probably only testing about 1 million people a week. That needs to be more like, 10 million people a day for us to really meet the need of what it would take for us to be able to identify positive cases, then isolate those positive cases through a form of social distancing, but also to contact trace the clusters in which those positive cases have been engaged with, and then isolate those folks. And that's when we begin to see the test numbers drive down. To answer the question of how long does it take to get results? Right now, the average is about 3 days. I know some people who have received results the same day, much quicker, depending on the infrastructure of where they get their tests. And I know people who it took much longer than 3 days. And so, again, we're only 2 months into something that is very new and very novel. We're learning new things daily, and people are trying their best to keep up, but we have been failed by a system that we rely on in the government, federally, and in many states locally. Those of us who live in Illinois benefit from decent leadership that I believe has done a good job, likewise in the city of Chicago, but that is not the case. And this is one of the consequences of having
and I want Ms. Love to jump in too. Sorry, I want you to finish your answer, but I want Ms. Love to jump in.
Sure. This is one of the consequences of having, a democracy where we essentially have 50 different democracies, and everybody can kind of do their own thing. So, yeah.
Thank you for that.
I just wanted to pull it out just a bit because I am not in the wonderful Chicago land. I don't live in Chicago, and I know a lot of the participants are in Chicago, but for those that might be outside of Chicago. So yes, we have a challenge with testing, but here's the thing. If you have symptoms, you should not be paying for testing, period, the end. And quite frankly, there should not be a lot of entities that are testing folk that don't have symptoms and that are asking to be paid to do that. There was a situation in Charlotte, North Carolina, and they found out there was a clinic who had gone and gotten tests, was charging, had a tent outside their building, charging $50. And this isn't the only place that we've seen this. And there was a problem with the test. And they knew it was a problem with the test. They had ordered these tests from Asia. They were not approved by the FDA, which is another reason people who say they have tests, that's a red flag for you. The tests that exist should be FDA approved tests and tests that are complementary, because we're in the middle of a pandemic and people that have symptoms need to be able to get tested. There's also a big push in a number of states, counties, and cities where they are creating sites in communities of color, because when all the news started coming out in terms of the data and the disparity, they wanted to make sure and be able, may not be happening everywhere, but it is happening in some places and spaces. So for those who are outside of Illinois, outside of Chicago, I just wanted to share that. Now, as Dr. Burley said, we're not going to, number one, get any federal leadership, okay? So it's going to continue to be a bit hodgepodge, et cetera, with the testing. But I want us to be forward thinking, because when we get to the point and there is mass testing, we need to be ready to ensure that that is done in a fair way, and that those who are the most vulnerable are tested first. That's getting ready to be the next big problem with testing. So we've got to get ourselves right, our thoughts right, our strategies right, to be able to push and ensure. Now I say this, and I'll wrap on this point. I'm a sports fan. I love sports, but I'm not in favor of professional players from sports leagues being able to be tested because they want to bring that sport back. Because that is taking tests from frontline workers, vulnerable populations, et cetera, because we don't have mass testing. So, that's where we are with some elements of testing. But if you have symptoms in your community, you should be able to get a test for free.
Thank you for that. And I also want to point to those that are watching that our team have listed some of the resources that our panelists, our speakers have shared, so you can see them listed there. Also, don't forget that we reach out to your alderperson, reach out to the mayor's office, especially if you're not seeing resources as Ms. Love shared, as Dr. Burley shared, that's readily available. Put pressure on these entities to say, we are an deeply impacted communities. When you're seeing numbers that more than 70% of Black and Brown communities are directly impacted by this illness, that's a significant impact on a community. And if we're not having access to test sites, if we're not having access to these resources, we need to hold our elected officials and our public servants accountable. And these are also areas that as faith communities, we can organize as well and join in with organizations like CRS that's committed to eradicating these disparities, to put pressure on our political officials. And which kind of leads to a question by Wilbert Watkins from Lockport, who wants to talk about the systemic remedy to systemic racism. What does it look like? And how can we help while sheltering in place? And so if we can tie that into the health disparities, and at some point before we wrap up, I want to make sure that we touch on other areas of health. I know, Dr. Burley, you're very concerned about those that are being impacted because of the stay in place, sexual violence, and we also want to talk about the mental health implications, the trauma, and all of those different intersections of health in this pandemic. But let's address Wilbert Watkins' question.
Sure. Well, Wilbert, thank you for your question. If I had the answer to that, I would probably be somewhere else right now. But let me first say we have to eradicate white supremacy, first and foremost. A Black man has to be able to run through his neighborhood without being chased down by a firing squad. We have to level the playing field, not just equally, but equitably, with the understanding that everybody is starting from the same place. So what does that look like in the form of healthcare? Well, first of all, I think, we have to give everybody healthcare. You can't beat a public health pandemic without 100% public access to healthcare, which is one of the reasons why we lag behind the rest of the world. South Korea recorded their first case on the same day that the United States did, and they have since flattened the curve and are moving to reopen and return to society as normal. And one of the reasons for that was because everybody had access to healthcare. So nobody had to worry about whether or not it was going to be cost prohibitive for them to get a test and then be treated. People just could comfortably and confidently do so. And so we've got to give everybody healthcare. And if we can't give everybody healthcare, then we need to give Black people and Native Americans healthcare in the form of reparations, medical reparations. That's first. Second, we need to consider a universal basic income. And this is something that's been touted by some of the presidential candidates in the past. And, we've even seen it be tested out in places like California, where every American citizen, no matter their race, class, creed, religion, or sexual identity or status, gets a universal income every month of somewhere between $1,200 and $2,000 a month. Those types of things begin to raise or level the playing field so that these disparities don't exist. Now, the reason why I can confidently mention these things as a form of eradicating systemic racism, because we have a federal government right now that has, out of nowhere, generated $5 trillion in the last 2 months to respond to this crisis, and will likely dole out even more money just to keep the United States economy afloat. And I bet if we did the math, that the price annually to give everybody health care and to give everybody a universal basic income would be maybe more reasonable than what we are spending right now as a result of having to respond to a public health crisis in an infrastructure where people don't have access to health care, where people don't have access to a livable wage or paid leave or health benefits in their essential jobs. And so, one of the systemic ways in which we can tide racism is to make society more equitable, aside from obviously eradicating things like white supremacy, white nationalism, whiteness in and of itself, this idea that, being white is better than or more preferred than anything else. And we have to begin to see that manifest in policy, not just in morale or ethic, but in paper from the federal government that then translates to a level of equity in communities of color, in poor communities, as it relates to this current moment that we're in and the moments that we'll continue to be in as a result of systemic racism.
Mm-hmm. Absolutely. And we have someone in the chat said, "Amen, Dr. Burley." So
that's exactly what I was thinking. Amen.
Yeah, amen. Definitely critical to speak truth to power, and address racism point blank. And that's why we're having this conversation. And before I take another question, let's talk about that. The fact that we're here, because when we're looking at mainstream media, when we're looking at the resources that's being shared publicly, et cetera, there may be issues or information or resources that's not centering on our communities. And so what are the questions that you're hearing in your work and the work that you're doing with Black and Brown communities and marginalized communities and all of those intersections we've spoken of? What information do they need to have access to that we need to lift up so that communities can feel empowered, feel protected, and feel resourced so that we can respond in a way that we've already addressed, the government, et cetera, may not necessarily be addressing directly?
So first I'll share that I was thinking about that question and preparing for this conversation. And I really like the African American Policy Forum website where they list their resources that are very much focused on communities of color in multiple languages, across segments, across audiences, across topics, and sharing a mix of resources, not just articles to read or websites to go to, but podcasts, sharing creative resources, poems, and then addressing topics that we know are very critical. And we started to touch on very briefly, like things around trauma, things around stress, depression, and how do we therefore do that? So American Policy Forum, AFPF.org, wonderful set of resources. So I wanted to say that first. What was the second part of the question?
Well, just being able to address what is not being stated. We're being made invisible amidst this pandemic. And so what are the resources and information as it pertains to these health disparities that we need to share with the community so that they can be empowered and tooled with information?
Go ahead, Dr. Burley. Let you sort of add to that part.
Sure. So I sit on the board of the National Minority Equality Forum, which is a health equity organization that has the largest database owned by any minority organization of patient files that then researchers can use to study these very issues that we are discussing around the social determinants of health. And so NMQF has been hosting weekly webinars every Friday around mental health and all of these other intersections as it relates to COVID-19, but also the restrictions of the shelter in place orders and how those in and of themselves can translate into trauma. And so, Reverend Dr. Middleton, you mentioned, domestic violence. Home is not a safe place for some people. In fact, in 2017, the CDC found that Black women, their homes was the most dangerous place for them in the country in terms of intimate partner violence. And so we've seen a peak in domestic violence reporting as a result of these shelter-at-home places all over the globe. And so that's something for us to keep in mind. You know, when we talk about people who are struggling with mental wellness, isolation sometimes becomes the enemy of someone struggling with mental wellness. So being at home alone isn't necessarily in their best interest. And so, you know, NMQF is producing a number of different resources around those issues. You talk about differently abled people, which include, you know, many people of color who have pre-existing conditions that make them more vulnerable to COVID-19. They need advocacy as well. Social distancing often impacts them in that their caregivers that they need to survive on a daily basis can't be as interactive with them as they need. Likewise, a lot of differently able people are benefiting from Medicaid. However, Medicaid only covers their services in long-term care facilities, which we know are hotbeds. And so we need to advocate for some expansion of Medicaid for differently able people to be able to cover their care in their homes so that they can be safe and not be put in a more vulnerable situation. You talk about immigration, advocacy there that needs to be happening. You know, right now, you know, earlier in April, we sent a plane of deportees back to Guatemala, and 75% of the passengers were COVID-19 positive. And so COVID-19 is now a chief export of the United States. And yet we're trying to prevent people from coming into our country. And so what does it mean to advocate for immigrants during this time, who include people of color as well? And so lots of resources available. Obviously, Johns Hopkins has been my go-to resource for scientific data. The CDC is still a reliable resource despite its connection to the federal government, which hasn't been so reliable. The National Minority Quality Forum is a good resource for communities of faith, specifically Black communities of faith. The Samuel DeWitt Proctor Conference has a coronavirus resource center and page with a depth and breadth of information as to how and which people of faith should cope during this time. And it includes a lot of health wellness aspects. And, you know,
we're going to try to compile all of these resources because I see some, and we're getting close to wrapping up as well. But we have a lot of interest and questions regarding some of the resources that you all mentioned, and we're trying to make sure that we list those resources here so that you can receive it live and go back. I know someone asked Dr. Burley if you could please mention the board again. They missed it so that we can.
Oh, sorry, National Minority Quality Forum, or NMQF.
And Ms. Love, you mentioned you said AFPF, or what was the organization?
African American Policy Forum, which is AAPF.org.
And we just listed that. And so we will keep sharing, even post this forum, this town hall conversation. And our speakers today also have their websites, which we will post at the end of this so that you can go directly to their website and be able to engage them directly. We won't be able to answer all of the questions, but I just want to just highlight some of the things that folks are lifting up here. Nathan Anderson wants to speak to universal income, disincentives for people to work. We also have Rick, who talked about universal guaranteed income. And we also have questions regarding faith communities being able to find resources to keep their church community together during this time. Mary Brown mentioned a recent blog post, Dr. Burley, that you wrote that addressed the pressure on churches to reopen in states where government leaders are prematurely opening. And so there's a great deal of interest in how do we specifically address this pandemic and the ways that it has an impact on our communities. And Ms. Love already spoke to the trauma. And one of the things, one of my professors from seminary would often talk about protracted stress disorder, because we're still very much in a state of trauma versus a post-traumatic stress matter. And so I want to talk about the rituals that we are being separated from at this time. I had a good friend whose mother has been in the hospital, in a nursing home for 3 months, and her mother just passed away this week. They're funeralizing her right now. And the first time that she had an opportunity to be near her mother in the nursing home, her mother is deceased, and they're telling her, okay, you viewed the body now and it's time to go. But in our tradition, sometimes folks want to wait until the funeral home comes before they leave. They don't want to leave the body. Not being able to have a proper funeral, a last rites ceremony per se with the body, or where people can come. Now people are driving by houses to show lament and mourning. And I'm wondering about those persons a month from now, 2 months from now, where it hits them that my mom has passed away and I wasn't there to hold her hand. I wasn't there to comfort her. I've read articles where people said that all they could do was listen to the rhythm of the breathing over the phone as their parent or loved one took their last breath. And people are doing everything they can to survive, to stay healthy, to stay well. But 2-3 months from now, I'm wondering about the psychological, the mental health impact that this will have on our communities, and a community that's already traumatized by racialized violence and the like. How do we speak to the trauma from a location of health, disparities, and an urgency to address trauma that we're facing as a community?
Well, I think first of all, we speak honestly, all right? And we need to be transparent about the fact that what you first started talking about, which is culturally, we have now become more fractured from, disconnected from our traditions. And that's a challenge within itself, because we are a people who fellowship, who come together, who celebrate, who encircle when there is the need. But we have to function differently. So one, if we feel, which is going to be natural, right, in this notion of separation, isolation, and disconnect, if we feel anxious, we need to say that. We need to be comfortable to say it to somebody that we are close to and that we believe that we can have that confidence and security in to be supportive of us. Secondly, I think now it's important, and no matter where you land on the faith spectrum, to begin to have certain rituals in this space of being separated, whether you're in your home alone, or even if there are people there, where you're able to have silence, you're able to deal with your breath, you're able to have a stillness, 15 seconds, 2 minutes, whatever it is, because we have to self-heal in some ways when we can't quickly get to these other resources. And the notion of breathing, calmness, and quiet and stillness will help us. And, I could go further, but we have to be honest and transparent now about the trauma that is on top of the trauma. So again, let's be forward thinking. Let's get ready now, because we're going to have to address it. And because the federal leadership is lacking, and we have so many states opening too soon, we don't know what that trauma is now going to put on some people in terms of increased cases. Now it's being reported, more fear that's coming.
And that fear part is real. When I think about my commute every day to work, it's on the bus, in the working class, the community that public transportation is all they have access to. And if you're already experiencing trauma of loved ones dying, or seeing the rate of how communities of color are impacted, and we open up, how do we go to work if you have to rely on the public transportation system and you're not feeling safe? and also just another layer of Black and brown bodies dying, you know, alongside police brutality, which, by the way, I want to, before we wrap up, remind folks that you can go to communityrenewalsociety.org and have access to a list of COVID-19 resources that our team has worked really hard to compile, and it will include the resources our speakers have shared with us today. And also you will see resources on our GAPA initiative, which is really urgent now more than ever to make sure that GAPA is passed when we're thinking about persons who are incarcerated and the impact of COVID-19 on the Black and brown communities that are disproportionately incarcerated. So please go to our website to receive more information about those resources. And I want, before we wrap up, I want to remind you that we will also continue this conversation next week on May 14th at the same time at 12 noon. We have a wonderful lineup of speakers as well. And we will be speaking on Jesus and the Disinherited, looking at socioeconomic disparities in communities of color. So we hope that you will join us for those conversations. But I don't want to just cut us off. This conversation is great. But I want to give Dr. Burley a chance to respond to the trauma piece. Thank you, Ms. Love, for that. And then ask you all to help us prepare to close out. What words would you give our community that's gathered here today to offer a word of hope, even with the health challenges and concerns that we may have as a community? How will you send us forth so that we will not feel helpless, but hopeful in this moment?
Thank you. So from a trauma standpoint, I come to it as a practitioner. And I think for practitioners, we have to get trained in and institute trauma-informed care. And so it's something that we have used in treating people living with HIV. It's this understanding that those who present to you come with baggage, likely trauma, and that their trauma informs their medical diagnosis. But that needs to extend not just for healthcare providers, but for pastors, as you mentioned, and people will still be reeling from the aftermath of COVID-19, and people are going to have to address that. And so we have to approach people with trauma-informed care, with knowing that they come having experienced something that they haven't yet quite dealt with. When we talk about mental health practitioners, trauma-informed care has to become the baseline in the aftermath of this moment, but also from our government. You know, they passed the CARES Act. I think eventually they need to pass a trauma-informed CARES Act, specifically for frontline workers, for essential workers, for people of color, particularly Black people and Native Americans who have disproportionately been impacted by COVID-19. You know, you mentioned earlier Katrina, and then there was 9/11, and these are events of our lifetime that everybody knows and remembers, and how there was support in place after those events. My proposition is that there needs to be a similar type of support in place for the people who were most disproportionately impacted by COVID-19 long term, whether it's a fund or the availability of services that people will need. But COVID-19 will come and go, and it will end, and we will return back to life. It won't be life as normal. There will be a new normal, but we will return back to life. But in the midst of that, there will be dry bones all over the valley as a result of COVID-19. People who will require long-term trauma-informed care as a result of what had happened now. And we have to all be in a position as practitioners to receive them with the understanding that they come maybe not as whole as they went into COVID-19 as they left. Finally, I want to lift up that it is National Nurses Week. And I just want to send a note of gratitude to the lifeblood of the healthcare system, nurses who, for all intent and purpose, are putting their bodies on the front line so that we can take our bodies off of it and stay in our homes. And so I really want to lift up nurses this week, appreciate them, thank them, and encourage everyone to continue to make decisions that are best for you and your household in the midst of derelict leadership that isn't necessarily making decisions in your best interest. We will emerge from this. The hope is that we emerge better than when we went in. And I encourage all of us, in the words of Miss Love, to take charge of our own lives and our own care in terms of how it is that we come out of this. But we will come out.
Thank you for that. That's very hopeful, Miss Love. He took your word, so what do you say now?
Here's what I want to say to all my brothers and sisters. First of all, remember, this is a moment in time. This is not forever. This is right now. And so we must continue to be nimble and flexible because we still don't know everything. But we are the ones leading the effort. Dr. Burley noted, we are the ones wearing face masks, social distancing, and honoring the policies that have been set in the places where we live. We have overcome worse, and we will overcome this, and we are going to be better.
Amen, Ashe. And one of the persons in the group responded with the word simply resilience. And when I think of the narrative of people of color, Dr. Burley mentioned Native community, Black and brown folks throughout the course of history. Resilience certainly is a word that speaks to who we are and how we have been able to overcome trauma, work through pain and suffering, even when we were stripped of the very resources of our land, our community, when our bodies were restricted, movement was restricted. We have within our DNA the capacity to survive. And so I want to encourage our communities to be mindful of our lineage and past and the resilience of those that came before us. And we cannot separate this present moment from that Sankofa, that past as well. And I want to encourage our faith communities, especially if you are in a faith community that may dismiss this and say, well, we're going to keep going to church. We're going to keep, having large groups or not having the social distancing or practicing those safety measures, to have the audacity to lament, to challenge, and to say, well, you know what, you can reopen the church, but maybe I'm just not going to show up. I'm going to keep watching online. We have the capacity to make those decisions for the health and welfare of our bodies, our communities, our families, our household. And as our speakers have shared today, in consideration of those that are on the front line, those healthcare workers, and also being mindful of those that are impacted, who are incarcerated, who are on the streets, and those elderly members of our community that are deeply vulnerable. Let's not forget that we are interconnected and that we should be mindful of these measures for safety so that all of us can come out to the other side of this. I am so grateful to both of you, Ms. Love, Dr. Burley, to our entire staff and team that's working behind the scenes, and to each of you that have joined us for this conversation today. We must continue to have this conversation, keep it going. Please make sure you visit communityrenewalsociety.org so that you can have access not only to the wonderful resources that we have compiled under our COVID-19 resource page, but also so that if you want to watch this town hall again, to be able to take notes or to really hear or share this resource with your community, you can certainly do that. It will be posted to our website and on our social media platform. Thank you, Dr. Burley. Thank you, Ms. Love. And thank you for just all of the wisdom and resource and hope that you brought to us today. We'll see you all next week at 12 noon, the same time, where we will talk about Jesus and the disinherited, the socioeconomic disparities that impact communities of color. Take care, everybody. Blessings.